And are these things that you prescribe and recommend to the patient and to the neurologist?
Yes. Yep.
You mentioned a couple of times MRIs and CAT scans.
Right.
Sometimes called CT scans.
Right.
Those are tests, advanced radiology tests like x-rays, but they're different. I don't want to get into all the technicalities of it, but they can take different pictures of slices
Right.
of the brain using
Different levels. Right. This way.
very sophisticated modern equipment, right?
Yep.
In your experience and based on your testing, do MRIs and CT scans always show the damage to the brain?
No. The rule of thumb is that an MRI something has to be this big, like the size of your pinky fingernail, in order for an MRI to pick it up. And sometimes, because like you said, they're taking slices, if the lesion falls in between a slice, it can be missed. It's less likely to be missed with repeated MRIs. But the problem with brain injuries is that the injury is on a microscopic, it's on a cellular level. So if you think about brain cells they're like neurons, okay, that's a brain cell. And this is the axon or the body, and then there's these little dendrites that come out, and they don't totally connect with the next neuron. There's a space in between there. And that's where neurotransmitters come in. Neurotransmitters are chemical bridges that allow the electrical stimulation to go down one neuron and jump that bridge and stimulate the next neuron. So when you're doing something like remembering your phone number, right, probably 50,000 of these neurons are firing in a second, in order to, for you to retrieve that phone number. What happens in a head injury is that there's these neurons get pulled apart. They get twisted and they get pulled apart. So now the space, the gap, the synapse between the neurons is too big for those chemical bridges to work. And that's why you have slower information processing. That's why you have people who can't find the right word to express themselves, because it's sort of reaching a dead end. The other thing about, the injuries to the brain that the MRI doesn't pick up or the CAT scan, is that it may not pick up like micro hemorrhages, like when little tiny blood vessels get broken, the capillaries. And, I just wanted to point out that, we talked about the skull sort of encasing the brain, but the skull is not a smooth surface on the inside. What happens is that there are these little bony protrusions or on the inside, so that when the brain gets shaken back and forth like this, it's rubbing up against those protrusions, and it's causing, little capillaries to break, and that's also affecting, Now, if it's a major blood vessel, then you're going to find a collection of blood, and that's going to be visible on the MRI. But if it's minor, as it often is, that's not going to be. So that's why, I tell people all the time, think about it in terms of structure and function. They're not the same things. Conversely, I've had people with huge, like slow-growing brain tumors that would basically wipe out their left frontal lobe, the size of a lemon. And on my testing, I couldn't find any functional impairment, because the guy was really bright, and this brain tumor was a slow-growing type. It might have been growing for 15 years, and it allowed him, because it was slow-growing, to begin to use his left frontal lobe to do things that the right frontal lobe, to use his right frontal lobe to do things that the left frontal lobe would normally do. So yeah, structure and function are two different things.
All right, so if I understood what you just said, there can be damage to the brain which would not be shown on these CTs and these MRIs.
Right.
So your tests, these standardized tests,
right,
that are used to determine all these functions, can reveal things that are not shown on the MRIs and the CTs.
Right.
You touched a little bit upon the neuropsychologist's role in recovery and treatment. Could you go into some detail about that? What's your job and how do you do it?
Yeah, so, once again, pattern analysis, we're looking for the strengths and weaknesses across all of those different functions. And the easiest way to describe that field is to say that, one of the things that we try to do, the easiest thing actually, especially with today's technology, is compensation. So think about it as a crutch. Like if someone has a knee replacement, they can get around, but they need a cast on their leg and a crutch. Example of that is, I was working with a professor a very sort of professor with some notoriety and popularity in the Philadelphia area, and who had a head injury. And he was in his 60s. He was able at this point to stand up and give a lecture, to 200 students with no problem until his head injury. So the compensation device that we used, because he wanted to continue to teach, is that now he had to use slides, whereas before he could just extemporaneously get up and he might use a few slides. But now the problem wasn't his memory, because what he was talking about was long-term memory, not short-term. The problem was his frontal lobe in terms of inhibiting him from going off on tangents. He would go off on a total tangent, and 10 minutes later think, oh my God, where am I? Having trouble finding his place. So we had him develop a slide presentation and use that slide presentation and talk from the slides. It's not changing anything about the way his brain is doing it. The changes are external. The changes are in the environment, right? Much like a crutch or a wheelchair. In terms of what happens inside the brain, I would say generally there are two categories of things we try to do. One is to try to exercise that same brain region that's impaired to get those neurons to get closer together, right? The more you work that area, the more blood flow goes the more you exercise that area, the more blood flow gets to that area, and it's helping those neurons heal. So in the example of a concrete example would be, one of the common things that head injury people have is word retrieval. The words on the tip of their tongue, they can't quite find it. And that would be this area, the angular gyrus of the left parietal lobe. This is where words are stored. Left side in the rear. So this is kind of the library. This is the stacks of the library where verbal information is stored. It has to go up this pathway called the arcuate fasciculus to the frontal lobe where it's actually spoken, right? So if a person has trouble with word retrieval, a speech therapist might give them pictures of different objects and have them try, more and more esoteric objects, less common objects, and have them retrieve the name. It just as a way of exercising, like you would, like if your arm came out of a cast, you would be exercising your arm. The other way that's a little bit more complicated is finding a different brain region. If this brain region is really impaired, let's say the area between the angular gyrus and the frontal lobe, the arcuate fasciculus, that's like a highway that connects these two areas. Maybe that's impaired, right? So we have to find a different brain region. So that's the area where I feel like we can be most creative, because as I said before, people who are really, really good at things learn how to use innately. They use other areas of their brain that most of us wouldn't even touch to get that thing done, but it has the potential to do it. So, to give you an example with a short-term memory example, which is, probably the most commonly reported symptom of, TBI. If I ask you to remember 4 words, let's say house, tree, cat, pie, how would you go about, how would your brain process that? How would you try to remember that?
In school, I would use initials.
Okay. Now that's very good. Yeah.
HTCP.
HTCP. Right. Now you have to remember those.
That's true.
Right. And sometimes people would make up make up, well, that's like HTCP, like ketchup, or it's thinking of some word that contains those. So it's one, so it's easier. Some people would do verbal rehearsal, house, tree, cat, pie, house, tree, cat, pie, house, tree, cat, pie. That's using the left temporal lobe, right? That's verbal memory. But if I asked you if the left temporal lobe is impaired because of an injury, if I asked you to just picture in your mind's eye a picture of a house with a tree in the front yard and a cat sitting on one of the branches in the tree, and maybe a blueberry pie on the front porch cooling off, right? Take a snapshot of that. Then you're using a totally different region of your brain. You're using the right temporal lobe, responsible for nonverbal memory.
Because my brain is recreating that picture.
Right. You just have to pull up that
in my
picture.
mind.
Right. I tell people all the time, say, a guy will say to me, my wife sent me to the supermarket to get 4 things. I can't believe I forgot one of the things. And she tries to tell me to take make a note, and I don't want to do it because it's so easy. I know I could do 4 things. And, he comes home with 3 of the 4 things. I say, just take a picture of those 4 things on the belt, the checkout counter. Just take a mental snapshot of what those 4 things are going to look like. And then you got it, you got it. Because it's using, a totally different region of the brain that, based on my testing, I know is less impaired than the left temporal lobe.
Let me ask you a different set of questions about your role in treatment and recovery.
Sure.
When I say post-concussion syndrome to you,
Right.
what does that mean?
Well, it's a cluster of symptoms that people with head injuries will have that are protracted, right? Most people with head injuries, mild head injuries, are going to recover within days or weeks, right? But if those symptoms of, they could be cognitive symptoms like memory, they could be vestibular symptoms, balance.
Right. When presented with a patient who has post-concussion syndrome,
Right.
and does have symptoms of a brain injury, of there being some damaged areas,
Right.
how do you go about developing a treatment plan for a patient like that?
Well, the first part is, to look at that pattern of strengths and weaknesses over testing. When I do testing, I'm not like, a bloodhound looking for deficit areas, because what I'm really assessing is the rest of the brain's ability to compensate for that. So if I see people, even if they're 3 or 4 months out, I'm testing their brain's compensatory ability, right? And that's what I want to push to the max in developing a treatment plan. The brain's ability to adapt and to compensate. That's both the creative part of what I do and also the hopeful part of what I do, because I'm amazed at what people can do with injured brains.
How do you work with the other doctors, speech pathologists, physical therapists, the whole rehab team,
Right.
to support recovery?
Well, yeah, I mean, it's a complicated process, and we work together as a team. Neuropsychologists is a fairly new field.
When did it start?
Well, it depends on how you say start, but in the 30s and 40s, of 1930 and 40, we began to have some people who are publishing and developing tests and things like that.
Yeah.
So it's a fairly new field. But when I was at Jefferson, so the answer to your question depends on your setting. So for the first 10 years, I was in psychiatry at Jefferson, and so I would consult with speech and OT people at Jefferson down in the rehab department, physiatrists, on a more regular basis in terms of a treatment plan. But even then—
Can I stop you for a second?
Yeah, sure.
That's speech pathologist.
Yes.
OT is occupational therapy.
Right.
And a physiatrist is not a psychiatrist. That's that's a doctor that specializes in rehab, right?
That's right.
Okay, I'm sorry.
No, thank you for that.
So you work with that team.
The rehab department at Jefferson was fairly short term. they were holding people for a few weeks, depending on, so the treatment plan was immediate but fairly limited. If I were working at a place like Moss or McGee, long-term rehab, then I would be more involved in the day, on a daily basis with team meetings with these people, seeing how these exercises were working, be measuring periodically, using my test to measure improvement, to see, how quick word retrieval was coming along, or giving memory tests to evaluate memory improvement, that kind of thing.
And to this day, there are neuropsychologists in hospitals that work with
Yes.
the rehab team in that very role, correct?
Yes, that's right.
Okay.
Yep.
And how long were you in private practice?
1990, like 40 years almost, right?
Well, that's great.
And that was, then I was in sort of an outpatient clinic setting, so I had less opportunity to hobnob with the speech therapist and the OTs. But in my reports, I would always make recommendations for treatment, as needed. And, sometimes I would treat people if they were very high functioning and didn't necessarily want to go to a rehab setting, where in the rehab setting, you're going to find more people who are more severely impaired, like moderately and severely impaired. Some people were, high functioning, mildly impaired people were a little skittish about even, they would find it depressing to go and to be treated in those settings. So they would prefer to be treated outpatient, which I was happy to do.
In your practice, does the treatment and recovery for mild brain injuries differ from that from moderate and severe brain injuries?
As I just said, the treatment for mild brain injury, many, depending on, once again, the pattern analysis and strengths and weaknesses, the age, the intelligence level, the motivation level, treatment could be done in my office, right?
You said you were always amazed by the recoveries and the adaptability of human beings.
Yeah.
Is it fair to say that it's different for moderate to severe brain injuries,
Yes.
the nature of recovery, than it is for mild brain injuries?
Right.
And can you explain why that is?
Well, more of the brain has been impaired. It's the more brain that's impaired, the less likely you're going to have a full recovery. So most mildly impaired people will recover. That's not so true with moderate impairment, and very untrue with severe brain injuries. So some of the hardest evaluations I had to do were severe brain injuries, maybe 2 or 3 years out. And the referral question was, can this person live at home with, 12 hours of support a day? Or do they need full-time custodial care? Those were tough patients.
And tough decisions to make.
Yeah.
And those really are important questions because at that point, the family is trying to think what's best for the patient, what's best for the family itself.
Sure.
What the costs are going to be.
Yeah.
I mean, there's all these confluence of
Sure.
Issues coming at the family at that point.
Yeah.
While we're there, before we move on to another area, is part of the job of being a neuropsychologist to talk to the family?
Yes, definitely. Yeah. We always have feedback sessions, and, the more family involved, the better, because it's a major trauma for the family. I mean, the person that they get back after a head injury isn't the same, and sometimes they call it the hidden, the hidden injury, because if you break your arm and it's in a cast, you're going to get some sympathy for that because it's clearly visible to the outside world. A head injury is silent. It's not seen, observable, sometimes not even by family members. And so it's very hard for them to understand why a spouse might have a meltdown, right? Or be depressed, or forget things at the supermarket. It can be very frustrating. So a lot of the counseling that I do over the years has been with spouses, children, parents.
In mild to moderate cases.
That's right.
When people hear the term mild, they assume it's not serious.
Right, and that's one of the things that I don't like about the classification system that you mentioned, like mild, moderate, and severe. Because, mild, first of all, mild brain injury, that classification can be broken down to complicated or uncomplicated. So a mild, uncomplicated head injury would be one in which there are no physiological markers like a skull fracture or bleeding on the brain, a hematoma, that kind of thing. A mild, complicated head injury, you can still have a skull fracture and bleeding on the brain, and it could still be technically a mild head injury, right? I saw one person, an older person, who fell and didn't even really lose consciousness. They had like an alteration. They were a little bit fuzzy for a few minutes, but their Glasgow Coma scale was near perfect. They were considered a mild head injury. 6 months later, they show up in the emergency room because they had a slow bleed from that fall that wasn't picked up by the CAT scan at the time because it had just started. But over 6 months, it got to be the size of like a lemon. And it really began to, their life was threatened. They wound up in the emergency room.
And that's what neurosurgeons.
And that's a mild, right. That's right. And that's a mild, classified as a mild head injury.
Can someone with a mild brain injury have a job disability?
It's possible, sure.
And can they have an inability to communicate and personality changes?
Yes, both.
And do you work with psychologists and psychiatrists in treating patients that have these issues, these post-concussive syndrome
Yes.
symptoms?
Yes. Yep.
By the way, on occasion, have you prepared reports that have been used, I'm sorry,
It's all right.
with respect to claims for disability,
Yes.
for Social Security, Medicare, Medicaid type claims? Injury claims where someone's injured either on the job or elsewhere.
Right. Yes.
And you've been accepted as an expert in court?
Yes.
And by the federal government?
Yes. Yep. Absolutely.